Sir, we are on live and we are starting sessions. So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare. Welcoming you all for the today's webinar of Fetal CNS arranged by Fetal Fetal Medical Committee, AMOX and Aurangabad OBG Society. And I would like to welcome the MOC for today's session, Dr. Sunita Kedkar ma'am. Madam is currently the consultant and director at Kedkar Maternity Hospital. Next slide, please. Yeah. Madam has done BGV, has vast experience for more than 14 years. Madam was the ex-professor at Vadia Maternity Hospital, Mumbai, and ex-consultant at MIT Multispecialty Hospital, Aurangabad. A doctor's field of interest is obstetrics, sonography, infertility, and menopausal health. With this short introduction, I welcome you, ma'am. I'm handing session to you for your further proceedings.
Thank you, Dr. Stalin, sir. On behalf of AMOX Fetal Medicine Committee, I would like to welcome all. Firstly, I would like to introduce today's convener, Dr. Sujit Singh sir. Sir is chairperson of Fetal Medicine Committee, AMOX. He has done his MBBS MD from GMC Aurangabad. He has done his basic UG training at Bimal Sahni Sir Sonoscan Center. He is FMF certified for 11 to 13 week scan, preeclampsia screening, Doppler and ultrasound, and fetal abnormalities. He is secretary of SFM Marathwada chapter. Sri Hospital is well-known center, UAG training center for Marathwada and all over Maharashtra. His fields of interest are fetal ultrasound. We welcome you, sir, and I'll request sir to share his words of wisdom.
Good evening, my dear friends, colleagues, and seniors. I am very much delighted to give a welcome speech on this occasion. I welcome our chief guest today, Dr. Sitapal ma'am. Ma'am, your words will be valuable for us. I welcome two pillars of AMOX, Dr. Rajendra Singh Pardesi sir, Sujata Dalvi ma'am, secretary. I welcome President Aurangabad OBGYN Society, Vare ma'am, and Secretary Dr. Vaishali Surase. I welcome our chairpersons today, Dr. Rita Bajaj and Dr. Prashant Ingole, who are very knowledgeable persons in the area of fetal medicine. I welcome our esteemed faculties today, Dr. Prathana Shah, Dr. Vaishali Munde, and Dr. Shilpa Satarkar ma'am, who are going to enlighten us with their great knowledge. I welcome to all delegates who have joined this webinar. About the topics today, until now we have finished first trimester in recent webinars. Now we are moving further. So first, we are going system wise. So today's webinar is about fetal central nervous system. So there are three talks. First talk is a very basic talk regarding normal anatomy of the fetal brain in second trimester, which will be delivered by Dr. Prathana Shah. Second talk will be by Dr. Vaishali Munde. She will be talking on posterior fossa lesions. And third talk will be given by Dr. Shilpa Satarkar. She will be talking about fetal ventriculomegaly. So thank you for joining. Over to Sunita for further proceedings.
Thank you, Sujit sir. Now I would like to invite and introduce our chief guest, Dr. Sita ma'am. She is chairperson-elect of Genetics and Fetal Medicine Committee, FOXI, for 2023 to 2025. And MD from Mumbai. She is clinical secretary of Bengal Obs and Gynec Society, 2022 to 23. Chairperson-elect of Genetics and Fetal Medicine Committee, FOXI. She is a fellow representative of AICC RCOG Eastern Zone, honorary vice president of Society of Fetal Medicine, Kolkata chapter. We welcome you, ma'am.
Thank you so much, Dr. Sunita. And at the outset, I'd like to thank Dr. Sujit for giving me and bestowing me this honor of being the chief guest for this wonderful program on central nervous system organized by AMOX. It's always a pleasure to be a part of anything associated with Maharashtra, as my alma mater is from Mumbai. And of course, Dr. Rajendra Singh Sarvi, who hails from the same place, and Dr. Sujata Dalvi. So it's a deep connect there. And AMOX itself, as I was telling Dr. Sujit earlier, Aurangabad has all the stars of fetal medicine there, with Dr. Bimal Sahni there itself, and all the budding stars like Sujit and my other friends as well. So, and a lot of good programs being going on. So congratulations, and thank you to Aurangabad Society as well for having me, Dr. Anjali and Dr. Vaishali. So looking forward to a great program. And as you have been going in systematic way, I think central nervous system is an equally important part, where we can do it, where we can see anomalies and suspect things in the first trimester. But the more of the diagnosis should not be, you should not be in a hurry to give it in the first trimester, because it's important to realize that things are evolving, especially in the central nervous system. Only by 18 weeks or 19 weeks, you can be sure that this is actually an anomaly. But there are suspicions, of course, if you can have gross anomalies, like acrania and stuff, you can terminate. But the consideration with central nervous system is that it is always evolving, and you have to wait till the particular time physiologically till the thing comes better. And I think it's, we're going to be enlightened by all the wonderful speakers we have. So first we have to know what is normal, and then go on to the very basic, very common finding of ventricular megaly. What is the significance? And I'm sure our faculty will enlighten us on ventricular megaly and posterior fossa lesions. So I wish you all the best, Dr. Sujit, for this wonderful program and all your programs ahead. I have been, some have had noticed that some of your programs have been really good. So congratulations once again, and thank you all. And thank you to Dr. Pardesi Singh sir and Dr. Dalvi ma'am. Thank you once again.
Thank you, Sita Ramgurtipal ma'am, for your words of wisdom. Then now I'd like to invite and introduce our guest of honor, Dr. Rajendra Singh Pardesi sir, President AMOX.
It's okay. It's okay. It's okay,
Welcome.
Sunita. Thank you. Respected Chief Guest, Dr. Sita Pal, Chairperson elect of Genetic and Fetal Medicine Committee. I'm proud to tell you that she is from our institution only. We are cyanites from Cyan Hospital only.
Yes.
And Dr. Sujata Dalvi, respected Dr. Anjali Vare, Dr. Vaishali Surase. I'm proud to be a part of this webinar with AMOX Fetal Medicine Committee and my society, Aurangabad. With my AMOX pillars, Dr. Sujit Konkar, Chairperson, and Dr. Sunita Khedkar, Youth Coordinator of AMOX. So, Dr. Sitapal, I want to just highlight our society, Aurangabad Society, is continuously doing workshops and seminars and CMEs on sonography since 2003. Aurangabad is the only society who has conducted MCI recognized workshop by Dr. Suresh and Dr. Pikesha in 2003. And Aurangabad is the society who has conducted many workshops, but whole 3 days conferences on USG with ISUAG also in 2016 and 2019. It's the only society. And we are conducting, and Aurangabad Society is very much interested. And there are stalwarts who are working in SFM also, like as you told, Dr. Bimal Sahani, Dr. Shilpa Satarkar, and Dr. Sujit Konkar himself. We know all that USG is now essential tool for obstetricians. We can say it's a third eye of obstetrician. Webinars, CMA, and conferences regularly. And I congratulate Dr. Sujit Konkar, who is the right person and who is the right chairperson of this committee. Dr. Varsha Munde, Dr. Shilpa Satarkar, and chairpersons Dr. Lalita Bajaj and Dr. Prashad Tinkul. It will be a great webinar. I wish every success to this webinar, and I wish every success to Dr. Sujit Konkar for his tenure as a chairperson. Thank you so much. Thank you so much.
Thank you, sir, for blessing us. Now I would like to invite Dr. Sujata Darve Madam, Secretary AMOX, to give her blessing speech. Dr. Sujata Darve Madam is consultant gynecologist from Mumbai. She has worked in Oroji Wadia Hospital, Jagjeevan Ram Railway Hospital. She is joint editor of Jogi, clinical secretary of Mumbai Obs and Gynec Society, first joint secretary of AMOX. Welcome, ma'am. Sujata ma'am.
Ma'am, join झाल्यात का?
Bhakte.
I can't see her joining.
Okay. Next, we would like to welcome our President, Dr. Anjali Vare ma'am, and Secretary, Dr. Vaishali Surase. We request Anjali ma'am to share her thoughts.
Good evening, friends. Respected Dr. Pardesi sir, Dr. Sita madam, then Sujit, Dr. Sujit, and all my friends. Sujit is doing very well. Now we are having very systematic approach to the sonography. Firstly, we had the first trimester, we had the webinar on first trimester. It was also very excellent webinar. Now we are having our own speakers, Dr. Prarthana Shah, Dr. Shilpa Satarkar, and Dr. Vaishali Munde. I wish all the best for this webinar. It will be definitely an academic feast. All the best. Thank you.
Thank you, Anjali ma'am. Now we'll move ahead to the academic session. To chair the session, I would like to invite Dr. Lalita Bajaj ma'am and Dr. Prashant Ingole sir. Dr. Lalita Bajaj, senior obstetrician and gynecology from Ventricular. She has work experience from Mission Hospital, Jalna. She has worked in MGM Hospital, Vadia Hospital, Kama Hospital, Prabhadevi Maternity Hospital, and private practice in Aurangabad since June 1999. She was past secretary of Aurangabad OBGYN Society. She is vice president of Aurangabad OBGYN Society, past cultural secretary of our society. She has done USG training from Vadia Hospital in 1998. Areas of interest are high risk obstetrics. Welcome, Lalita ma'am. Welcome. Then second chair. Yes. Second chairperson is Dr. Prashant Ingole. He is director at Pariputi Hospital and Test Tube Baby Center. The center is based for USG and infertility. Welcome, Prashant sir. Now I'll request Lalita madam to introduce and invite our first speaker, Dr. Prarthana Shah madam, to give her speech. Over to you, Lalita ma'am.
Yes. Dr. Prarthana Shah, can you hear me?
Yes,
Yes.
I hear you, ma'am.
Okay. Dr. Prarthana Shah, she is going to talk on normal fetal brain in second trimester. Dr. Prarthana Shah has done MBBS and MD DNB. She is a consultant of fetal medicine at Cape On Hospital, Aurangabad, specialized in high-risk obstetric and fetal medicine. 10 years of experience in this field. Has presented paper and posters in state and national conferences. Worked at various prestigious institutes at Bangalore, Mumbai, and Pune. First maternal fetal medicine consultant of Marathwada region. Now working for more than 5 years in Aurangabad. Has successfully completed 500 fetal invasive procedures, including intrauterine fetal transfusion in Aurangabad. I request Dr. Prarthana Shah to start with her talk.
Am I audible, sir?
Yes.
Yes, yes.
Yes, yes.
At the outset, I would like to thank Aurangabad OBGYN Society and AMOG's Fetal Medicine Committee, Dr. Sujit Konkar sir, Dr. Anjali Vare madam, and Dr. Pardeshi sir for giving me this opportunity. At the same time, I am a bit worried as I'm going to talk about one complex system of the body. I hope this webinar, this lecture will be of some use whenever we are going to be, practicing the CNS examination in our day-to-day life. Is it visible full screen? Yeah.
No, ma'am.
Is my screen visible? Not?
Screen is visible, ma'am, but it's not full screen.
Okay. Now is it okay?
Oh, ma'am, the screen is not at share.
Just. Are the slides seen?
Yes, ma'am.
Okay, fine. So whenever we talk about CNS examination, the three questions that we want to know is why we want to examine the fetal CNS, what information we are going to gain from it. Second is, yeah.
Can you make it the full screen, ma'am?
Yes.
Yeah.
That's fine.
It's not it, ma'am.
In my screen, it is seen as full screen.
Try clicking on a slideshow, ma'am, on the top.
Yes, ma'am. Slideshow
Okay.
from the beginning. From the beginning.
Yes. Fine. That's fine.
I'm not able to see full screen, ma'am.
Now?
Not yet, ma'am.
Unshare करून परत share कर.
Yeah, just a second. Is it seen now? Slides are seen?
Slides
Yes,
are
ma'am.
visible. Yes, ma'am.
I don't know.
From the beginning, ma'am, near that save option, there is an option called as from the beginning, ma'am. Near below that, ma'am, below that one. Below the home screen, from the beginning. Yes.
Now?
No, ma'am, it's
Ma'am, try it without presenter mode. Just once.
Means how to do that? How do you want me to do that? Presenter mode.
Like as you make your PPTs without presenter mode. Just escape.
Let me close and start. Is this okay?
No, not seen.
I think we can continue without full screen also.
Yes,
no? You
ma'am.
can
Yes,
see
ma'am.
at least.
Sure.
Yeah.
yes, ma'am.
So the three
Not
questions.
shared, ma'am.
You can see my slides, right?
No, ma'am, no, ma'am. Now it is not visible.
Slides only are not seen now.
No, ma'am.
Can you see now?
Yes, ma'am.
Yes,
Yeah.
ma'am. Yeah, ma'am.
So three questions that we want to, sorry for the trouble, we'll start again. Why we want to examine the fetal CNS, how we are going to examine it, and when should we do the examination. So these three questions I think we should be able to answer at the end of this today's whole webinar. So in this, whenever we say why is CNS examination important, we all know that brain is a complex organ and it's constantly evolving. We know especially during the 9 months of pregnancy and even later of stage of the life, there are lots of changes which are going in the brain. So whenever we are examining the brain, we should know at what gestation, how the brain should look. Unless we know this part, it is difficult for us to interpret what we are able to see. And that's why we are going to have some part of anatomy and some bit of embryology in this normal brain presentation today. Basically, what we need to understand is a normal structure that we see in sonography doesn't mean that function is normal. But abnormal structure, if we are seeing that there is some changes, morphological or structural changes in the brain, there is high chances that the functional part of the brain is going to be hampered in some or other way. And hence the long-term effect of the same is what we are looking at. And that's why it is very important for us to know that we are looking at a normal brain. because it is not just one child for us, that's for the family. It is going to have a long-term effect of a neurologically hampered child to take care of. If we look at incidences, if we talk only about neural tube defect, it is somewhere around 1 to 2 per 1,000. But if we take into account all these various CNS defects, this incidence can increase as high as 1 in 100. And that's why we need to pick them up at the right time for proper counseling and diagnosis. If we look at the image which is given down, which I have just taken from Google, but we can see that how are the changes in the brain are going to take place only during the first 9 months of life itself. And that's why we are going to look at it at the right time of pregnancy. How we are going to do is there are two systems that we need to examine the CNS. Everyone who is going to do anomaly scan has to look at some standard views for the brain examination. But if we find any variation in the standard views, if any suspect arises, if there are any specific indications like previous child has any neurological deficit or a family history of any neurological disorder is there, then we need to step up the examination level to a targeted neurosonography, which is done in indicated cases. It's a multiplanar type of diagnostic examination, and it's indicated in particularly high-risk patients where we are looking at some or other positive findings. Now, when we look at neurosonography, what are the machine requirements or what are the basics that should be available in our hand to proceed with this? If you look at only basic CNS examination that we do as a part of TFA scan or anomaly scan, then it can be a transabdominal with a normal probe of 3 to 5 Hertz, with a grayscale and harmonic imaging in proper use of color Doppler, with a PRF set at 20 to 40. But if we want to go ahead with the advanced neurosonogram, we need to step up from transabdominal to transvaginal approach also. So both these approaches give us additional information. The probe also needs to be of a better penetration. So instead of 3 to 5, we need a 5 to 10 megahertz. And here we can add a 3D ultrasound also. But definitely 3D is not compulsory for a proper neurological examination. A grayscale imaging also can give us a proper and complete diagnosis. So when we look at anatomy, if we remember our first year of MBBS, we start studying the human body in the three planes: the axial plane, the coronal plane, and the sagittal plane. These are the same three planes that we are going to discuss today in the CNS examination of the fetus also. So when we examine the fetus, we are going to balance both things. One is the quantity part of it, and second is the quality part of it. For example, we are measuring a biparietal diameter, that's the quantity part of it. But at the same time, we have to look at the structures as how they are formed. That's the quality of part of it. So whenever we discuss these planes, we are going to balance both these components whenever we go ahead with our further examination. The ISOG has given a very nice and basic statement that the one who wants to examine CNS should be familiar with the normal CNS finding, and that's what my lecture is about today. Let us learn first what is normal. Then only we will be able to say that yes, there is something different here from normal, and then we will be able to diagnose as what exactly is the abnormality there. Now let us start with the basic CNS examination. Here again, as I told, quality and quantity. When we look at the quantity, that is what we measure when we examine the fetus head, the biparietal diameter, BPD, head circumference, occipitofrontal diameter, atrium of the lateral ventricles, transcerebellar diameter, and depth of the cisterna magna. In addition to this, we can add the nuchal fold thickness, which is a part of aneuploidy screening. What should we look for when we are measuring these things is the shape of the head. How are the lateral ventricles? How is the cavum septum pellucidum? How are the thalami? How is the cerebellum, cisterna magna, and spine? I am not going to cover spine today because itself is a huge topic to discuss. So let us talk about shape of head. Most of the cases that we see are a normal variant. Many patients get referred to us saying that yes, the fetal head is small, madam, please examine. And when I look at the head, what many of us find is the biparietal diameter is lesser for the period of gestation, which is common to have a variation because change in the shape of the head. So what is important for us to look at the size of the head is the head circumference. What can be the normal variants in the fetal head is the oligocephaly, where we can see that the shape of the head is a bit oblong. But if it is more of round and circular, then it can be because of brachycephaly. Now, how to tell whether these changes are normal or abnormal is based on an index called cephalic index, which we calculate by dividing the biparietal diameter with the occipitofrontal diameter, and we multiply it by 100. The normal cephalic index should be between 71 to 78. So if the cephalic index is abnormal, then only we call that the shape of the head is abnormal. Otherwise, as I said, majority of the cases, the head is going to be a normal variant only. So what can be the abnormalities? I have just enlisted them for us to know that yes, these can be the variations in the shape of the head. As you can see in here, the frog appearance, that's the absent skull cranium. Any defect in the posterior fossa will give due to encephalocele. A clover lip skull can be because of the sagittal suture which has been closed prematurely, or a banana shaped skull with a lemon shaped skull with a banana shaped cerebellum, where we can see a neural tube defect or spina bifida. These are the variations in the abnormal variations in the shape of the skull. Now let us look at the basic planes that we look in the examination. These are the three planes that we are going to discuss today: transthalamic plane, transventricular plane, and transcerebellar plane. Now this is a simple image for us to know, as in the axial section which are the planes that we are discussing today. Let us start with the basic plane that we do in a biparietal diameter measurement, which is a transthalamic plane. Even in a transventricular plane, many people measure the biparietal diameter. What are the anatomical landmarks that we should look for? We all know the arrowhead sign. So what exactly is the arrowhead sign? We are looking at the cavum septum pellucidum. We are looking at the interhemispheric fissure, the thalama in both sides of it, the hippocampal gyri, which is seen here, and the frontal horns of the lateral ventricles. Here we are looking at the shape of these, presence of these, and then we go ahead with the measurement, that is a quantity part of it. So whenever we measure BPD, we know we should measure from the one which is proximal to us, that is outer, to the inner. That should be the way we measure the biparietal diameter, and the head circumference should cover the shape of the full head. Now let us look at transventricular plane. Here we have two parts to consider. This is a nice article from Prenatal Diagnosis 2020, where they say that we should divide this into anterior complex and ventricles, that's the posterior part of it, and then reassess and assess them in detail properly. So when we look at the transventricular plane, the first thing that we should look for the sutures, that's the coronal suture and the lambdoid suture. Are they there? Whether they are fused or normal. In the anterior complex, we are looking at the cavum septum pellucidum. Let us remember the word itself, cave, with cavum. That means it's a space, it's an empty space between the two septi, right? The anterior horns of the lateral ventricle, the corpus callosum, and the interhemispheric fissure. These are the structures that we are looking at the anterior complex. What are the anterior horns? These are the two comma shape. This is very important because they are fluid-filled structures which are separated medially by the cavum septum pellucidum. So any variation in the cavum septum pellucidum will alter the shape of these anterior horns. Now, what exactly is cavum septum pellucidum? As I told, it's a cavity which is fluid-filled between two thin membranes. It should be visible after 17 to 18 weeks of pregnancy or after a biparietal diameter of 44 millimeter. So if we are examining the fetal brain at 16 weeks of pregnancy, we may not be able to see CSP, which is a normal variation. Similarly, after 37 weeks of pregnancy, the cavum septum pellucidum fuses, and hence we will not be able to see it. Still, it doesn't mean it is abnormal because it is visible till 37 weeks of pregnancy. So a non-visualization before 16 weeks or after 37 weeks is normal. But in between the 17 to 37 weeks, if we are not able to see, that can be a clue for a partial or complete agenesis of corpus callosum. So this is how it should be seen, a rectangular or trapezoid type of shape separated by the two thin membranes. Now here you can see that's the figure on the right left is a normal cavum septum pellucidum, whereas that on the left is the absent cavum septum pellucidum, and hence we can see that the shape of the anterior horns is altered here. Now this is just an image to show in different planes how the normal corpus callosum will be seen and how it will be abnormal. So the fourth one image here is a normal cavum septum pellucidum. As I told, the anterior horns will be here in a comma shape, whereas the down image we can see a nicely teardrop ventricles, which is because of the absence of the CSP. Now this is another image to show a normal square or rectangle type of CSP. That is the normal image, and hence these are the anterior horns. But if this part is missing, the shape of the anterior horns will be a teardrop shape. Now what are the posterior portion part that we are looking at? We are looking at the occipital horns of the lateral ventricle. The atrium is characterized by the glomus of the choroid plexus. Now this glomus occupies the whole of the lateral ventricle here, and hence we are going to measure it next to the glomus of the choroid plexus. It should be a inner to inner measurement, and throughout the pregnancy, this measurement should be less than 10 millimeters. Let us remember, if we see a lateral ventricle of 9.5, that is not a prominent lateral ventricle, which we see in many of our reports. It is a normal. Unless it crosses a figure of 10, we are not going to say that the lateral ventricle is abnormal. Now, the image should be standardized. It should be adequate in adequately enlarged image. It should be exact axial section. Ambient system should be seen. CSP should be seen, and the location of the measurement should be next to the parieto-occipital sulcus, as nicely seen in this image. That's the parieto-occipital sulcus. That's the glomus of the choroid plexus. So we are going to measure inner to inner for this. Anteriorly, the CSP is seen. That's how we should measure. But sometimes when we are trying to measure the lateral ventricle, we need to measure both, the one which is proximal to us and one which is distal to us. And sometimes we are not able to measure it in the correct plane. We need to tilt the probe a bit to get a proximal measurement also. It is very important and imperative that we measure both the ventricles, the proximal and the distal one. And how should we document that yes, we have measured? One way of doing it can be, we let us split the image and have measured both. So we know at the end of examination that we have not missed out on measuring both the lateral ventricles. This is very important. Now, the one I was mentioning about the normal, if this is a normal, this is the image of a normal CSP, and hence the shape of the lateral ventricle is like that. The anterior horns are normal comma shape, whereas here we can see nicely that the teardrop shape has come because of the absence of the CSP there. Now let us move from the transthalamic and transventricular plane to the last one, that is the transcerebellar plane. Here we need to tilt our probe a bit, and this way the first two planes, that exactly axial planes we are looking at, but here we have gone bit up and posteriorly we are trying to go through the cerebellum here. Now what we are going to see here is the two cerebellar hemispheres, which are butterfly shaped or dumbbell shaped, and in between joined by the echogenic vermis. At the same time, we are able to see a fluid filled cisterna magna. We are going to measure the transverse cerebellar diameter, which correspond to the period of gestation during the mid trimester of the pregnancy. We are going to measure the cisterna magna from posterior surface of the cerebellum to the anterior surface of the occipital bone, and if the anterior posterior diameter of cisterna magna should be less than 10 millimeters. Sometimes we are able to see the keyhole sign till around 17 or 18 weeks of pregnancy also. That is because the inferior vermis has not still formed completely. So the keyhole sign can be normal till 19 weeks, and hence we need to reassess these patients after 19 weeks to confirm whether the diagnosis we are talking about is correct or not. That's how the cerebellum should look. That's what the cisterna magna is. And we know that there are certain septations which we can see in the cisterna magna, and we should not confuse with them with the wall of the Blake's pouch cyst. Now, this is the vermis. We know it is echogenic, and we can see the fourth ventricle in front of it. Now, what are the quantitative measurements that we covered till now in the axial planes? Biparietal diameter, head circumference, atrial width, transcerebral diameter, cisterna magna, and NFT as a part of the aneuploidy screening. Now, what are the limitations for this examination? Is the most important is the difficulty in examining the proximal structures, because the part of the brain which is close to the probe will have the effect of the calvarium, and hence we are able to see and examine the distal part of distal half of the brain neatly. Also, the midline structures we may not be able to see correctly in axial planes in detail. If we want to look at the median structures in detail, the axial section may not be adequate. We need to step up the further examination findings with the median plane or a sagittal sections. What can be indications or clues in the axial section that will tell us that now the basic CNS examination is showing some variations, clues for us to pick up that yes, this examination needs to be upgraded to neurosonography. Variations in CSP like absent or abnormal shape and size of the CSP, abnormal anterior horns, or they can be asymmetric pointed horns, dysmorphic features in any part of the brain in axial section, a large cisterna magna or open fourth ventricle, which is we call as a keyhole sign, a small cerebellum, midline space occupying lesions, or history of any midline abnormalities. We need to step up from axial to further examinations. Or other, apart from axial section findings, these are another list of the indications that for neurosonography. Like if we find a monochromatic twins, we need to go for neurosonography. If we are having any congenital heart disease, that means a major structural defect is seen in the heart, we need to examine the CNS also. And there is a list that we can see. The important part is the infections. When we are suspecting fetal infections, we should look for the lateral ventricles in detail for the evidence of any infections and calcification in the cerebellum and other parts in the periventricular areas. Now, in the neurosonography, we are going to examine two planes. One is sagittal plane and the second is coronal plane. In the sagittal, again, we have median sagittal and parasagittal, and there are four planes that we examine in the coronal plane. Now, these are just images. Transfrontal, transcaudate, transthalamic, and transcerebellar are the four caudate planes that we are going to examine. If we see here, the axial plane was the one that we are looking at here. Coronal plane is exactly perpendicular to it. We all are already have been examining the fetus in a coronal plane of the face, where we look at the nose and the lips of the baby. That is a coronal plane that we are looking at. So we have to start examining from that and just take our probe posteriorly toward the posterior part of the brain of the skull. And we are going to get one after these four caudate coronal planes. The first one in the image, as you can see, imagine that we are cutting the fetal brain through this. What structures we are going to see here? The interhemispheric fissure, the fetal orbits, these are important. Sometimes we can see the frontal horns of the lateral ventricles also, and the sphenoid bone of the skull will be seen in this plane. Now let us move the probe still further behind posteriorly. We are able to see the transcaudate plane. Now here importantly what we are able to see is the interhemispheric fissure, which is being interrupted by the triangular shaped cavum septum pellucidum. There is frontal horn of the on both sides, and the caudate nucleus is seen nicely. Also, we can see the sylvian fissure bilaterally in this section. Now, let us move the probe still further. That was the transfrontal, transcaudate. Now we have come to the transthalamic plane. In the transthalamic plane, in addition to the interhemispheric fissure, the frontal horns, and the corpus callosum, we are able to see the thalami. If we put the color box on, we can see the circle of Willis blood vessels here, and also we can see the optic chiasma near the base of the skull. Still take the probe posteriorly. We are going through the cerebellum of the fetus. So it is a transcerebellar plane. As you can see, there are posterior, the occipital horns of the lateral ventricles can be seen here. Also, if we are suspecting any Vermeer's abnormality, it helps us to differentiate between the cerebellar hemispheres and the Vermeer's here. And the calcarine fissure will be seen around 22 weeks of pregnancy. I'm not going to discuss the sulci gyra in detail today because that is not actually a part of a basic examination that we're discussing. Let us talk about the sagittal plane. The clue for us here is the anterior fontanelle. We are looking through anterior fontanelle. So the window is anterior fontanelle for us to give the median section. And if the same, keeping the probe at the same place, we are just tilting it laterally and we are getting the two parasagittal, that is right and left parasagittal sections. Why is it important? Is for numerous situations this gives useful information. If we have any doubts in the axial section, again we get the additional information. And anatomy and physiopathology, unless we know properly, we will not be able to pick up correct findings, which is abnormal here. For example, if we see here, this is an image from Dr. Ramurthy sir's presentation, and he has given it so clear and simple way. This is our probe, which is in the axial section. Start moving the probe toward the top of the baby's head till we lose the fetal head, and then rotate the probe through 90 degrees. We get the the sagittal section of the fetal head. Now, very importantly, in the parasagittal, this is the image that we should remember. I have just taken it from the Google, but the structures seen here are very important, and that this is how, if we keep this image in our mind, we will be able to correlate with what we are seeing in the ultrasound, and hence we get the hand-eye coordination unless we know the image in mind. So always compare this image to what we are seeing in the ultrasound. Okay, so this is the anterior horn of the lateral ventricle, that's the posterior horn of the lateral ventricle, and that's the temporal horn. Same way, anterior horn, posterior horn, and the temporal horn. So it's also called a three-horn view, the parasagittal center. Now in fetal infections, we tend to get a nice calcification foci here, and also the periventricular parenchyma and the cortex will be affected in fetal infections. So parasagittal section gives us information. Let us look at the mid-sagittal. Very important that we remember these structures. What we are able to see is in the mid part of the brain, we are able to see the corpus callosum and its four components. And that's the midbrain and the brainstem. That's the cerebellum, which is just like piggyback, sitting there like a piggyback on the midbrain. And in between two is the fourth ventricle. Now, if we look at the corpus callosum, the four part of the corpus callosum we know. The splenium is the posterior most, the body, the genu, and the rostrum of the corpus callosum. All four we should be able to see properly. Now, if you look at this plane, how are we going to acquire the midsection? Depending on where our probe is in relation to the fetal head. If we are looking from the posterior fontanelle, we are able to see the posterior part of the, that is the splenium of the corpus callosum and the cerebellum in proper way. If you are looking at sagittal section, we should be able to see the whole corpus callosum. From the anterior fontanelle, this is the part which is seen clearly. And if we are looking here, metopic suture, the anterior most part, that is the rostrum and genu, will be seen clearly. Now let us look at this image again here. See, this is the part we are looking from the anterior fontanelle, so we are able to see only this much. That doesn't mean we are missing on the splenium. We may not be able to see it clearly from the section. So we need to move our transducer in both directions. Here we can see nicely, and there are various measurements that we can do where we are suspecting that the corpus callosum, thickness of the corpus callosum, various parts, and there are nice charts available online for us to have a look at and compare and decide. So the same sitting, we can see that this is nicely sitting cerebellum here, fourth ventricle, and that's the brainstem there. If you look at this image, which is a 3D rendered image, if we can, if you see till now, I have been giving only information about the grayscale and the 2D imaging. 3D has not played any role. This is for just for all of you to have a look at how the brain will be seen in a 3D. Most importantly, the splenium is the one which should overhang the tectum. If it is not overhanging the tectum, that means there is something wrong with the splenium of the head. That's what we should look at in this plane. Now, this is just to magnify. That's the brainstem of the fetus. That's the fourth ventricle, and that's the cerebellum. At the same time, cerebellum should be seen in detail, the quality part of it. Now, if we put the color box on, we can nicely see the pericallosal artery. In a normal fetal corpus callosum, when it is there, it is like this. But any part of the corpus callosum is missing, the radiating form will come here, and that's what will be give us clue that yes, we are missing somewhere in the corpus callosum. Now again, this is an image to show that that's how the mid-sagittal section will look if the corpus callosum is missing. In the image, this is nicely seen, that's the pericallosal artery, and here we can see the radiating vessels there, multiple radiating vessels. Now in the vermis, very important, it's a nicely echogenic part that we can see. Dr. Ramurthy sir says very nicely, we put the probe on and we take the image, and it's a nicely white part that is seen, which is like the rest of the brain is gray, whereas the vermis is seen nicely white colored. It connects the two cerebellar hemisphere. The normal shape is kidney bean shape. This is very important. A kidney shape, bean shape cerebellum is normal. Vermis is normal. So any variation in the shape, again we have various charts to compare the size and shape of the vermis. And the location again is very important. If it is uplifted because of various posterior fossa pathologies, which we'll see in our next session, that will give us further clues. There is various measurement like BT angle and BB angle, which will be covered in our next sessions. Now, what is the role of 3D in the neurosonography? As I told earlier, 3D is not mandatory. But yes, if we want to use it, definitely one single section will give additional information about other two sections that we are looking at. Other two planes also will be given in the same sitting. So it is time efficient, it is time saving, it helps us to get quick images, and also it's easy if we are into using a 3D. But if you are not a 3D person, then definitely on the basis of grayscale finding, by going through the all different planes that we discussed, definitely we can reach a diagnosis. Also, the advantage of 3D is if we save the clip, we can go back to them later on also, even if the patient is not in our table. This is again image from a Google article, tomographic ultrasound imaging. What we saw in the coronal planes, we have to move our probe one after another to take different planes, different sections. But here you just click one and the computer itself gives you different sections in just one volume collection to us. So again, it is a time saving, but not much for a diagnosis. So just to summarize, axial section, we know transthalamic, transventricular and transcerebellar. These are the three planes that one should examine each and every time that we are looking, even at the basic CNS examination. Sagittal and caudate are the additional examinations that we do as a part of neurosonography. Sagittal can be median sagittal or parasagittal, right and left parasagittals. Caudate can be transfrontal, transcaudate, transthalamic and cerebellar. Sorry, it should be a coronal plane. So what we need to do is normal views should be there in all sections. We try to do even in a normal patient, try to have a look at the sagittal section, try to have a look at coronal sections. So once we start seeing them, then the image fits in our brain, and then it's important, then it's easy for us to correlate it with the normal anatomy. Then we will be able to pick up, yes, there is something variation from the normal. Let us go ahead further with the detailed diagnosis. That should be the way it should be. So thank you all for your patient listening. Thank you again, Aurangabad Visual Society and AMOG's Fetal Medicine Committee for giving me this opportunity. I know CNS is a bit tiring. For me also, it's always a bit tension kind of personality situation when I'm looking at any CNS anomalies.
Thank you.
Excellent talk.
Yes,
Rather than
Lalitha.
everything as if baby is outside the uterus. Can you hear me?
Yes,
Yes,
ma'am.
ma'am, I can hear you.
Prarthana has explained the central nervous system examination as if baby is outside the womb. We can do all the sections of the brain. It was really excellent. How much advance has happened in ultrasonography that we can come to know. Otherwise, it was difficult. Before anatomical only we were knowing the anatomical finding can be, if there is any cyst or some anatomical pathology can be only picked up. But the way you have explained all the sections, it was really excellent. Thank you. Thank you.
Thank you, ma'am.
Thank you, Prarthana, ma'am. It was a very excellent talk.
Thank you, Sunita madam.
Now I'll request Dr. Prashant Ingole sir to introduce Dr. Vaishali Munde ma'am. Prashant sir. Dr. Vaishali Munde ma'am is going to speak on posterior fossa lesions. Prashant sir.
Sunita, you can read the biodata for.
Okay.
If sir is not there, Ingole is there.
Be busy. So Dr. Vaishali Munde ma'am is leading fetal medicine consultant from Nagpur, active body member of ICUOG CME Task Force Committee since 2018. She is faculty trainer for Fox recognized ultrasound training courses, faculty at Fetal and Gynec Committee. She owns academic page on Facebook, Vidarbha Fetal Medicine. She is member of Society of Fetal Medicine Maharashtra. She has done fellowship in medicine for 2 years at Bangalore Fetal Medicine Center. She is FMF certified for invasive procedures, nuchal translucency, and fetal abnormalities. Her areas of interest are fetal screening strategies, fetal echocardiography, fetal
That's fine,
neurosonography.
Sunita ma'am, that's fine. I'll just start it. It is a big topic. Thank you so much for the lovely introduction. And sorry for interrupting in between because I don't think I'll be able to finish in time. Just shall share my screen. Is it okay?
Yes, ma'am. You can start.
Yeah. Is it visible?
Yes, visible.
Yeah. So posterior fossa lesions, we all know small brain but large confusion, right? So it is very difficult to differentiate between different kind of posterior fossa lesions, including multiple cysts and other communicating structures. So let us start with the basics of posterior fossa. Just I won't be explaining in detail about the anatomy because it is already explained to you. Just basic points so as to learn about the abnormalities. Before that, we'll start with some normal. So posterior fossa at 8 weeks, it is all about fourth ventricle. Yeah, you can see this. I'll be using a pointer for a second. So you can see that these are different parts of the brain: forebrain, midbrain, hindbrain, right? And the posterior fossa, it includes only large cystic structure, and that is the fourth ventricle. On top of the fourth ventricle, you can see this is a small choroid plexus. This is again a fourth ventricle in different plane, fourth ventricle and choroid plexus. So in the first trimester or in the early stages of the pregnancy, the fourth ventricle is on the top. The cerebellum sits there, and slowly it elongates caudally to cover the fourth ventricle. So posterior fossa at 12th week. This is the posterior fossa on the left at 12th week of gestation. Again, here the large cystic space behind, near, like just above the, you can see the behind the midbrain is the fourth ventricle. And again, the same thing is shown in the rendered view. Anatomical landmarks, yes, as we have already discussed, axial plane, it is one of the important planes wherein we rule out most of the CNS anomalies. So in anatomical landmarks, we see cavern septum pellucidum, midline interhemispheric fissure, and posteriorly we see cerebellum. Cerebellum, anterior to the cerebellum, anterior to the vermis, we can see fourth ventricle. Posteriorly, we can see cisterna magna, and we try to see that if there is any communication between the fourth ventricle and cisterna magna. Sagittal planes, it is one of the crucial planes when we doubt something on the axial planes, and we all should learn how to take sagittal planes. So here sagittal plane again includes, there are 2 points which are the, or you can say polismens of the sagittal plane, and these are median vermis and the corpus callosum. If we see corpus callosum and vermis in one plane, we are definitely in the mid sagittal plane. So in mid sagittal plane in posterior fossa, we try to see that the vermis is well seen. It has all its fissures and lobes. And anterior to the vermis, we need to see the fourth ventricle, and posteriorly we see normal space, that is cisterna magna. This is a sagittal plane, just to show. So anatomical landmarks in the sagittal plane, what we see here in the first image is the fourth ventricle of a baby, which is 11 weaker. This is the axial plane of a baby, which is 11 weaker. Herein we see fourth ventricle and a remnant of choroid plexus. Here in the second image, it is a 17-week pregnancy wherein the part of vermis is seen, and the fourth ventricle is seen as open structure. It is communicating to the posterior fossa, which is normal at 17 weeks, because that's how it forms. And this is a 20-weeker baby wherein the complete formation of the cerebellum and the vermis is happened completely, and we don't see that any communication between fourth ventricle and the cisterna magna. A thick echogenic part between two cerebellar hemispheres is seen, and that is the vermis, and it is complete. There is no communication seen. So on routine analysis of posterior fossa, what do we do? Ultrasound in axial plane, is it sufficient? So on axial plane, normality of the posterior fossa is based on the 3 criteria. What do we see in the axial plane? Normal cerebellar anatomy, 2 hemispheres and vermis without any communication between fourth ventricle and cisterna magna. Cerebellar biometry, we look for cerebellar measurement, that is one of the crucial parts. And third is we look for the retrocerebellar fluid space. We see that the cisterna magna, as we all know, the cutoff is less than 10. So if anything above 10 millimeters, we call it as increased retrocerebellar fluid space. That is increased fluid into the cisterna magna. So how do we suspect the posterior fossa abnormalities? Large retrocerebellar space with or without communication between the fourth ventricle and cisterna magna. Small transcerebellar diameter, either it can be globally small or partial reduction of the cerebellum. Abnormal echogenicity, that can be global or partial. So once we see something abnormal, a careful analysis of some important anatomical structure should be performed. What do we investigate? Cerebellar tentorium, vermis, and brainstem. anatomical landmarks of the cerebellum in mid-sagittal plane. What do we look in cerebellum? We look for 3 lobes in each hemisphere. It is very difficult to see it on the ultrasound, but we try to look for as much as cerebellar tissue possible. So it consists of 3 lobes, anterior, posterior, and FN lobe. And the cerebellum has folia, which are transversely oriented gyra. So in this image, we have I have shown you omni view, or a plane or section cut through the cerebellar tissue, and the same is reconstructed into the other image, which is on the right side. So I will again use the pointer. Yeah, here. So this one is vermis. This is a cerebellum, and this line, can you see my pointer? So this line going through the cerebellum is representing this image. This image is seen after going through this line. So this is not vermis, this is a cerebellum. As madam has already said that cerebellum is echogenic in the periphery. However, it is hypoechoic in the center. This is unlike vermis. How do I remove this? Okay. So let's go to the, so this is the cerebellum, which is shown here. Now go to the next anatomical landmarks of mid-sagittal plane of vermis. Here again, I have used the same technique, but this time the light is going through through the vermis, cutting it. And on the right side, you can see that vermis in the previous image and in this image, vermis in the previous image was the previous image, it was periphery, it was hyperechogenic, and center it was hypoechoic. However, here it is throughout hyperechogenic, and this is vermis. So vermis is considered intact when it is possible to visualize intact fastigium of the 4th ventricle. Here I have labeled the fastigium just behind the pons, that this is indentation just exactly into the middle part of the vermis. Hello, can others be muted? I'm not able to focus. Hello, Dr. Sneha? Yeah, thank you so much. And the 3 lobes of the similar vermis with the 2 fissures, primary and secondary fissures. So as we see here, this is MRI image. This is from Google, not by me. But here it is very well explained that vermis, primary fissure, then you can see 4th ventricle, tentorium, cerebelli, torcula, and anterior bulge of the pons, cisterna magna. All these are important landmarks in the posterior fossa. The same I have created in the 3D rendered view, wherein first one is mid-sagittal image, second and third images, one is axial and another one is coronal image. So 3D imaging aids to 2D by better defining the spatial relationship of the CNS structures in 3 symmetrical planes. So why it is important to look for vermian or cerebellar abnormalities? Because those are associated with dysphagia, dysarthria, hearing loss, cognitive affective symptoms, cognitive impairment, autistic behavior, and hyperactivity behavior. How to proceed? Okay, so we start with the axial plane. What do you look? Large retrocerebellar space is seen, or small TCD is seen, or abnormal echogenicity is seen. Then look for any associated CNS or non-CNS anomalies. If you don't see any associated anomalies, how to proceed with this large retrocerebellar space or all these findings is look for the shape of the 4th ventricle. If it is normal, it is not. Normally, the 4th ventricle is rectangular structure in axial plane, and it is a triangular structure in the mid-sagittal plane. Look for position of the tentorium, where it is situated on the neck. So look for primary fissures of the vermis. If the primary fissure, whether the primary fissure is seen, and look for the ratio of the anterior and posterior lobe. Normally, posterior lobe is twice the anterior lobe. Look for that ratio if possible. And then go for the structures like pons and look for any mass effect by the fluid. So how it is distributed? One paper by Gandolfi et al. In 2012, it was published, Prenatal Diagnosis of Posterior Fossa Anomalies, in which they have seen that the most common anomaly was Blake's spouse cyst, which was very commonly seen, followed by megacisterna magna, Dandy Walker malformation, and Vermin hypoplasia. So large, here I will start with large retrocerebellar space without any communication between fourth ventricle and cisterna magna. Very important, without any communication. So what do we expect here? Megacisterna magna or arachnoid cyst. The close differentials will be these two. So both of them have good prognosis. Almost 97 to 100% of them will have a fair outcome. So these are the two cases wherein we see in the first image it is megacisterna magna, and second it is arachnoid cyst. So again, the second point, large cerebellar, retrocerebellar space with communication between fourth ventricle and cisterna magna. Here the cerebellum can be normal or abnormal. Which are these cases? This can be Blake's spouse cyst, Dandy Walker malformation, or Vermian agenesis or hypoplasia. So you can see here, these are the three images on postnatally on the autopsy. We can see that in the first image, it is a cyst slightly elevating the cerebellum or vermis, you can say. This, in the second image, the vermis is elevated more, and the third image, you can see the anatomy of the vermis is not complete. So what is Dandy Walker complex? Previously, this Dandy Walker complex includes three entities, but they have similar sonographic appearance on axial planes, that is open fourth ventricle. So these three entities used to come under the Dandy Walker complex entity. So what are, now before we go with the diagnosis and the cases, I'll explain you all these cases. I have few cases which I'll show you later on. But before you go with actual case scenarios, let us know what is BV angle, what is BT angle, and why it is important. So BV angle, see here carefully if you, okay. So here you can see that this is the cerebellum, yeah, vermis. This is the pons, and this is the tentorium. So BV angle is an angle which is a line drawn tangentially to the dorsal aspect of the brainstem. Here you can see that this line, this is the first line for BV angle, and second line is drawn tangentially to the ventral contour of the cerebellar vermis. So whatever angle is interspersed here, that is the BV angle. And what is the BT angle? The same first line, which is tangentially drawn to the dorsal aspect of the brainstem, and the second line is drawn tangentially to the tentorium, which is nicely, we can nicely do this on ultrasound, or we can render the images, and from that we can calculate BV-BT angles. So okay. So next, go ahead with BV angle. BV angle at mid gestation, the angle was, there was a study wherein the BV angle was calculated on the large number of population, normal and abnormals, wherein the study reproduced these values that BV angle was less than 18 degrees in most of the cases. And in Blake's spouse cyst, it was less than 30 degrees. However, in Dandy Walker malformation, it was more than 45 degrees, and anything between 30 and 45 degrees was seen in Vermian hypoplasia. So, position of the tentorium, vermis clearly visualized, position is normal or slightly uplifted, vermis is clearly visualized, primary features of the vermis are intact, but there is mass effect, little bit of mass effect. What can it be? It can be Blake's spouse cyst. So here we see that this is a pictorial demonstration of the Blake's spouse cyst, and here in this image, both the cerebellar hemispheres are separated by a communication or keyhole. It is keyhole or the communication between the fourth ventricle or the cisterna magna, which is lined by some epithelium. You can see here on the both sides, it is shown that Blake's spouse has a that cyst has a structure wall, which can be easily demonstrated by ultrasound also. And sometimes the echogenicity inside the Blake's spouse cyst and outside Blake's spouse cyst, that is into the fluid of cisterna magna, varies. because outside you see different septations, however inside it is more clear fluid. It is hypoechoic than the fluid outside. So it is found that black spout cysts, in many studies, that black spout cysts are usually benign findings, and those are normal anatomical development. Sometimes it gets delayed, so we can see it. So complete vermis with normal height and the vermis is shifted. Sorry, complete vermis with the normal height of the vermis is seen. Slight uplifting can be seen in black spout cysts. Unlike Dandy-Walker malformation, it is a very frequent anomaly. So here in first image, we can see that the cerebellum looks nice, intact, and when we go little bit downwards, we can see that there is communication. Between postventricular and cisterna magna. So closure of the cerebellar vermis, this is a great study done by Bromley, and this was published in many papers and publications. So it says that it concludes that the prenatal diagnosis of vermian hypoplasia should not be made before 18 weeks of gestation, because development of cerebellar vermis may be incomplete at that time. You can see on the right side, this is a chart wherein on the left of the chart, these are gestational weeks of the pregnancy, and in middle there are number of fetuses showing communication, and on the right there is number of open vermis. So number of open vermis, you can see above 17 weeks or above 17 weeks 5 days, there are different cases which are showing the open vermis or open fourth ventricle. However, below that, below 18 weeks, there are no babies which are showing the communication. So that is why it is important to see this, that we are at the right gestation to diagnose this. So what are the key features of Dandy-Walker malformation? Here you can see that there is marked rotation of the vermis, enlarged cisterna magna, and vermis can be normal or defective. So huge space, huge posterior fluid in the posterior posts are causing pressure effects on the cerebellum, and even the vermis is rotated severely. So incidence of Dandy-Walker malformation is 1 in 25,000 live births. Low incidence of familial recurrence. It can be predisposing factors can be warfarin, alcohol exposure, or infection. It can also be associated with chromosomal abnormalities, and macrocrania is due to hydrocephalus or massive enlargement of the posterior.
Excuse me, screen is lost. Screen is lost.
Is it? Okay. Is it seen now, sir? No?
No, not yet.
Okay, 1 second. Again, I'll share the screen. Is it seen? Is it seen?
Yes.
Okay, I'll start from the slide. Okay. So, oh shit.
Yes.
Again from the start. Sorry for the inconvenience. Okay, is it seen?
Yes.
Yes, ma'am.
Okay, thank you. So prognosis depends on associated CNS anomalies, onset of hydrocephalus, and appropriate treatment is required. Mortality rate is 27%, and intellectual development may be normal in 50% of cases. Remember here, 50% can be normal, however, 50% will have neurodevelopmental delays. So 68% of the cases have associated CNS anomalies like dysgenesis of corpus callosum, heterotopias, ergyria, polymicrogyria, and 20 to 33% of the cases have peripheral malformations like cleft lip palate, cardiac and urinary malformations. So what is cerebellar vermis hypoplasia? Initially, it was under the Dandy-Walker. It was considered under Dandy-Walker variant, and that was cerebellar hypoplasia. Now this term is no more used. Dandy-Walker malformation is no more used. Sorry, Dandy-Walker variant is no more used. Frequently accompanied, the vermian hypoplasia is accompanied by CNS and non-CNS malformations. It can be associated with multiple genetic syndromes, and often it has a worse prognosis than Dandy-Walker malformations. So what is important to look in how to diagnose Vermeer hypoplasia is look for the shape of the fourth ventricle. As I have told you, what is the normal shape in axial and sagittal planes. Look for any primary fissures. If you can see primary fissures and three lobes of the vermis, or anterior and posterior lobes of the vermis nicely, that is the normal shape of the vermis. Is there any the ratio preserved or it is altered, and what are the dimensions of the cerebellum at follow-up? Is the pons normal? These all things are very important to diagnose Vermeer hypoplasia. It is one of the difficult entities, I can say. And about abnormal echogenicities, yes, in intracerebellar hemorrhages, we can see abnormal echogenicity of the cerebellum, either focal or complete. So this is now I'll start with the case scenarios. I think this will be good to know about the abnormalities, more particularly all these three abnormalities. So this is a case one. What you can see here, this is axial plane of the brain with nice normal ventricles and CSP. However, we can see that cerebellum is also normal, but behind the cerebellum, the space is enlarged. And once we measure it, it is more than 10 millimeters, which is 11.9 here. However, there was no communication between fourth ventricle and cisterna magna. So what is the diagnosis? Megacisterna magna. We move on to our next case. Herein, you can see that this is mid-sagittal section of the fetus. Sorry, the baby was not coming to the position and I had to show it this way. But here you can see that there is communication between the fourth ventricle and cisterna magna. Cerebellar hemispheres are widely separated. There is on a section, mid-sagittal section or mid-sagittal rendered image, you can see there is slight elevation of the vermis. And on measurement, the vermis appeared normal for the gestation. The measurement was about 10 millimeters. Vermian height was about 10 millimeters. So this is again a Blake-Spouse cyst, wherein in the second image, axial plane, wherein I have shown the communication in the axial plane, you can see that it has a nice epithelium lining it. So this is case 2, wherein baby is 20 weaker. You can see that cerebellum, is it normal for the gestation? Yes, it is corresponding almost to the 21 weeks. However, in the posterior fossa, you can see the expansion of the ventricle into the cisterna magna. As I already said, there is a keyhole sign and we can see what it is. It is a Blake-Spouse cyst. This mother came to me for the second opinion in view of hypoplastic nasal bone. So I have shown that image on the right corner. I followed up, I looked for other markers, then I could find this Blake-Spouse cyst. Then again, I went ahead with the further findings. I can further add 2 more findings into this. There was echogenic bowel as well as persistent left superior vena cava. So I was suspecting something, some chromosomal abnormality. That's why I told her to go for genetic testing. And this is a 3D rendering image of the same baby. She underwent genetic testing wherein amniotic fluid was tested for fission karyotype, which showed abnormal karyotype. This baby had trisomy 21. So the couple was counseled regarding the same and they terminated the pregnancy. This is the, sorry, they did not go for termination. They were very religious and they thought that this baby will be okay after birth. And this baby, the mother had abruption and secondary, she delivered because of this. She was sectioned in emergency because she developed severe PIH. This is the baby postnatally. So remember that Blake-Spouse cyst, though it has a normal outcome most of the time. If it is associated with other markers, it is always mandatory to go for fetal karyotyping or testing like microarray and DNA storage according to your ultrasound findings. This is a case 3, wherein again you see that both cerebellar hemispheres are widely separated. How is the vermis? It is elevated nicely, and the measurement of vermis was almost 6.2 millimeters, which is really not good for this gestation. This is a mid-gestation baby, right? So This is a Vermean hypoplasia. Sorry, this is the second case wherein you can see that I have rendered one image. How do you find this image? This baby is 29 weeker, and here you can see that this is the cerebellum. Okay, and in the second image, cerebellum in mid-sagittal plane, we can see vermis, right? Nicely seen. And the 3D rendering image also shows both the cerebellar hemispheres with the central echogenic vermis. Now, these are the measurements of this baby. The transcerebellar diameter measured 24 millimeters. Is it normal for this gestation? 24 definitely for a baby which is 29 weeker is not normal. It should not be. It should have been somewhere 34 to 36 millimeter at least. And the height, however, the height of vermis was almost normal. And this is a baby with the normal anatomy. I have shown just to compare the two images, wherein the transcerebellar diameter of the same weeks of 29 weeks only, the transcerebellar diameter measured 36 millimeters. This is again the normal baby at the same gestation with TCD measurement 36.7 millimeters. So this is a case of wherein vermis is normal, but cerebellar diameter is small. It is measuring small. This is a case of cerebellar hypoplasia. Case 4, herein you can see huge cystic or huge space, huge enlargement in the and more fluid into the posterior fossa. The angle is BV angle is also increased. It is almost more than 60 degrees, and slightly some remnants of vermis are seen. So this case is Dandy-Walker malformation. So this is case 5. You all know this case, but still just addition to it, there is hypoplastic posterior fossa. You cannot see any cisterna magna there. Reduced transcerebellar diameter, the shape of the cerebellum, it is abnormal. Yeah. Here again, transventricular plane, the ventricles were normal, however, the shape of the skull was abnormal. So what we see here, lemon and banana signs. Yes, you are right. Look at the spine, and here you can see in the sagittal as well as axial sections, there is small defect, right? It is Arnold-Chiari malformation, showing the cranial signs and the descent of the posterior fossa because of spinal abnormality. So this is one of the rare cases. I don't have good images to show. These are from Google just to add to the topic. Absence of cerebellar vermis and fusion of two cerebellar hemispheres is called as rhombencephalosynapsis. It is you can see here that the cerebellar folia are nicely connecting to each other, and there is no interrupting vermis in between. So, and usually in this case, the fourth ventricle is rectangular. It loses its shape, as I told you in mid-sagittal section. The vermis should be the fourth ventricle should be triangular. Fastigium should be indenting the vermis exactly in middle. So the fourth ventricle shape is abnormal, and there is huge belly thickening of cerebellar peduncles, which is shown by many people on MRI as well as on ultrasound. We call it as molar tooth sign. There are other syndromes also in which you can see molar tooth sign. And here in axial plane, the first images are that of normal, and the images which are below are that of abnormal VVs. Wherein the first, the images which are above, they show normal fourth ventricle, and the other images, the fourth ventricle is, the shape of the fourth ventricle is abnormal. So it is good to look at the shape of the fourth ventricle in axial as well as sagittal plane. So what are the additional confirmatory findings? Yes, MRI, autopsy, and postnatal pathological examination is really needed to confirm the diagnosis of all these findings, because even on ultrasound, there are many things which we can confuse. We might call it as Dandy-Walker malformation. Recently, in a conference at Goa, Professor Malinger said that they had a case of Dandy-Walker malformation. They said to the mother, yes, everything will be all right. She went back. Again, after a few days, she came for follow-up, and there they could see that the vermis was elevating, the BV angle was increasing, and there was very much up rotation of the vermis, even with tentorial, in the tentorium was uplifted. So they followed the pregnancy post and they said that this is only black spouse stitch, but how to say it that it is not, because now the angle is increasing. Is it a Dandy-Walker malformation and all that? Postnatal, it was confirmed that it was black spouse stitch only, causing with increased fluid inside it, causing compression effects on the baby's cerebellum, and the worm is lifting it more. So all these are confusing terms, and more is getting added to it. We need to focus, we need to keep us updated. Previously, what was called as Dandy-Walker variant is now no more, the term is no more used. So all this is required to update your knowledge and be ready with your diagnosis. Thank you so much. Thank you all.
Thank you. It was excellent talk on posterior fossa. You have explained everything, and that too, you have explained in a case-based manner. 1 number, 2 number, 3 number, the way you have explained, everybody can understand. Now we don't think that there are so many problems related with the central nervous system, but one patient is more than sufficient for us to explain everything to them. So it is very good presentation, really very inspiring to learn from you people.
Thank you.
Thank you.
So
Thank you.
Yeah.
Now the next talk is by Dr. Shilpa Satarkar. She is going to talk on ventriculomegaly. She did her MD radiology. Now at present she is a director at Antaranga Sonography and Color Doppler Center, Aurangabad. Her experience is ex-associate professor at GMC Aurangabad, ex-professor at Medical College Ahmednagar, practice in ultrasound since last 27 years, national and coordinator at Samrak team of IRIA, working for preeclampsia screening to reduce perinatal mortality in India. She is a state and national faculty at state and national conferences, basic course of fetal radiology by MSBIRIA. She is faculty there also. Her presentation and publication, she has presented paper at World Congress in ISUOG, at Singapore in 2018, at Berlin in 2019, at Glasgow in 2020, and online in 2021. Publication in various national and international journals. Her area of interest are obstetric and ultrasound, gynecological sonography, and hepatopancreaticobiliary ultrasound. I request Dr. Shilpa Satarkar to start with her talk on ventriculomegaly.
Thank you, Dr. Lalita, for that so nice introduction. Me and Lalita are really classmates from first MBBS, and it's really heartwarming to see you introduce me. And I really thank Aurangabad OBGY Society and AMOG's scientific committee for giving me the opportunity to have the talk here. So I'll just share my screen. So hope you are able to see the screen.
Yes, ma'am.
Yes, ma'am. Yes. Okay. So ventriculomegaly, as we all know, is one of the most commonly found abnormality when we do the fetal scans. Basically, as such, it itself is not a diagnosis. It's something which points. It's not an anomaly, but it's a pointer. It is a presentation of something which is at some other place. So it can be a presentation of anomalies of brain and other organs, and they forming a syndromic condition like, or it can be a presentation of chromosomal anomalies, or it can be a presentation of infections. The incidence is around 0.3 to 1.5 of all the mid-gestational fetuses, with a male preponderance of around 1.7. Now, by definition, how we define ventriculomegaly? Let me clear you one thing at that. When we say that it is a ventriculomegaly, we are talking only about the lateral ventricles. When third and fourth ventricle are involved, we explain them, or we write in the report separately about the third and the fourth ventricle. So by definition, ventriculomegaly, it includes the enlargement of the lateral ventricles. It is secondary to accumulation of the excess of fluid. Now the normal ventricular diameter which we take at the level of the atria is usually stable throughout the gestation, and it is between 7.6 plus minus 0.6 millimeters. And when these lateral ventricular diameter at the level of atria, it is more than 10 millimeters, then we say that it is a ventriculomegaly. Previously, this criteria was also used, that the separation of more than 3 millimeters from the medial wall was used, but now it is a blanket criteria that if the atrial diameter is more than 10 millimeter, then only we say that it is a ventriculomegaly. So ventricular measurement is basically done at the level of atria. So atria is a place where the frontal horn, the parietal horn, and the occipital and the temporal horn, they all meet. So this area, why we measure at this area? Because it is stable throughout the gestational. Whenever the dilatation occurs, because it is at this junction of three levels, it is the area which dilates earliest. Thirdly, technical, if we take the technical issue, this area, the walls of this ventricle at this level is perpendicular to the beam, so that we can see the walls very clearly. And also because of that, the visual assessments become very easy. So what are the criteria for appropriate measurement? So when you say the ventricular measurement is like more than 10 millimeters, many of the times patients come for a second opinion to us, and actually because of the improper measurement, the ventricle is falsely enlarged. So the criteria to, we need to follow certain criteria to measure the lateral ventricles. So the head should be in the transventricular plane, the image should be magnified, the focal zone should be at an appropriate level, the midline should be properly, the FARC should be proper, and the both hemispheres should be of symmetrical appearance. And then we have to measure the atria and the occipital horn. They should also be very well seen in this image, and then only we are going to measure the lateral ventricles in this image. And then we have to remember that measurement of the lateral ventricle is perpendicular to the ventricular axis. So this is the ventricular axis. The measurement should be perpendicular to this axis, and it should not be perpendicular to the midline FARC. So the measurement should not be like this. Okay, the measurement should be perpendicular to the axis of the lateral ventricle. And then where we are going to measure it? We are going to measure it at the level of the parieto-occipital sulcus. This is the parieto-occipital sulcus. Here we are going to measure. At times when we do the measurement at around 18-19 weeks, because the parieto-occipital sulcus we are going to see 19 weeks onwards. If by chance the parieto-occipital sulcus is not developed, then we take the measurement at this level of the glomus, this part of the ventricle. And the measurement again should be, we have to use the plus caliber, the same as we use in the NT, and the measurement should be on to on like this, from the inner end to the inner end. So these are the criteria for developing, for measuring the lateral, ventriculomegaly or the lateral ventricles. And the measurement of the lateral ventricle should be a regular part in your anomaly scan. Eyeballing should never be there. You have to measure, may it be whatever value is there, you have to measure the lateral ventricle in each and every anomaly scan. So what is the pathophysiology of the ventriculomegaly? So it can be pathology of the CSF flow. As we all know that the CSF is basically produced by the choroid plexus, predominantly contributed by the lateral ventricular choroid plexus, and then few by the third ventricle and the fourth ventricle. So these CSF, it is produced here, and then it goes to the third ventricle, via the aqueduct to the fourth ventricle, and then it goes to all the subarachnoid spaces, and then by the arachnoid villi, it is absorbed into the sagittal sinuses, and thus the circulation is completed. So there can be obstruction to this CSF flow, or there can be some disease which cause poor absorption by this arachnoid villi, or some disease which lead to excess production of the CSF, like the choroid plexus papillomas. And then there can be ventriculomegaly can also be because of the abnormalities of this cortical, the cortex which is surrounding the ventricle. And commonest cortical abnormality is the corpus callosal agenesis. And then the ventriculomegaly can also be secondary to destructive lesions caused by vascular insults or by the infections. So once we understand the physiology and the pathology, then the understanding of the disease and the approach towards the disease becomes very important. Yes, can we diagnose ventriculomegaly in the first trimester? In first trimester, basically the criteria of more than 10 millimeters of the lateral ventricle, it does not fit. So what is there in the first trimester which points towards the ventriculomegaly? So the normally we see that the ventricles, they snugly fit in the lateral ventricles. The choroid plexus snugly fit in the lateral ventricles, and very little space is there surrounding the lateral part of the ventricles here. So in ventriculomegaly in first trimester, we see small, thin, dangling choroid plexus. The choroid plexus fill less than half of the ventricular spaces, and then there is significant separation from the medial and the lateral walls of the ventricles. So these are the criteria. These are the basically objective criteria. Do we have certain subjective criteria? Because eyeballing again will lead to confusions. Like if I feel that it is ventriculomegaly, somebody may say no, it is not ventriculomegaly. And these are beautiful 2 papers which will help you regarding if you want more reading regarding the first trimester ventriculomegalies. So for the specific objective criteria to identify the ventriculomegaly, this Marigold and these workers, they have found out certain criteria where they have taken ratios of various dimensions of the choroid plexus and the lateral ventricle. So they have taken the ratio by, that means the choroid plexus length divided by the lateral ventricular length, the choroid plexus area divided by the lateral ventricular area, and the choroid plexus diameter divided by the lateral ventricular diameter. And these ratios, when they found that the ratio of the length and the area is very very helpful rather than the diameter ratio. So what they found that in ventriculomegaly, these nearly in 94% of the patients who later turned out to be ventriculomegaly in the second trimester, they found out that the ratios were less than 5 percentile when the choroid plexus length and the choroid plexus area were included. While it was in only 82% of the patient, it was below 5th percentile where the diameter was used as a criteria. So the criteria of length ratio and the area ratio is more important to identify the ventriculomegaly in the first trimester. Now, whenever we see ventriculomegaly, we have to grade the ventriculomegaly. So there are 2 schools of thoughts which grade the ventriculomegaly. One school of thought say that we have to define it as mild or borderline, where the lateral ventricle is between 10 to 15 only, and then overt ventriculomegaly, where the lateral ventricular diameter is more than 15 millimeters. But then these Society of Maternal and Fetal Medicine, these paper, they say that no, we have to divide the ventriculomegaly or grade the ventriculomegaly like mild ventriculomegaly like 10 to 12, from 13 to 15 it is moderate ventriculomegaly, more than 15 millimeters is the overt or a severe ventriculomegaly. Why this thing is like these 3 gradings are really important, because when it is, they found that between 10 to 12, the outcome and the likelihood of having the neurodevelopmental abnormalities is different than that of the moderate and then that of the overt. So basically these criteria were proposed that between 10 to 12 it will be a mild ventriculomegaly, and they found that the likelihood of the normal neurodevelopmental is more than 90% in the mild group, while it is nearly like neurodevelopment can be normal up to 75 to 93% in the moderate ventriculomegaly. And this is very important to counsel the patient. We can tell the patient that the chances of the adverse outcome and the potential abnormalities are more with moderate than with the mild group, and definitely severe ventriculomegaly or the overt ventriculomegaly, as we know, have a very poor prognosis. So this is absolutely important. This grading is absolutely important for the counseling of the patients. Then how do we approach? So basically, sonographic approach basically depends on the fetal position. When it is a breech position, then you can go up to the fundal area, and then we have to do a transabdominal evaluation in various planes. And when it is a vertex presentation, we can go for a transabdominal as well as a transvaginal multiplanar fetal neurosonography. Transvaginal neurosonography is absolutely amazing. We see amazing pictures, and the detailed anatomy and everything is seen so perfectly. So always prefer for a transvaginal when we see any CNS abnormality. We have to use the highest possible transducer. We have to take and acquire the 3D volumes, and then we have to evaluate that. And after this CNS evaluation, we have to do a thorough fetal fetal anatomical evaluation to rule out any extracranial finding and to look for the markers. And in some cases, we may require, like if the patient is too fat, or if the position is not proper, then in that cases we have to go for the MRI also. So the standard basic planes, as Dr. Prarthana has very well explained, are the transventricular, transthalamic, and the transcerebellar plane. These are the axial planes. And then when we see ventriculomegaly, we have to do all the extended neurosonogram planes, where there are 4 coronal and 3 sagittal planes. So the first is the transfrontal, transcaudate, transthalamic, and the transcerebellar plane. And then we have to evaluate the ventricles in the mid-sag plane and both the right and the left parasagittal plane. So this extended neurogram is must in every case of the neurosonogram. And the evaluation of the spine also is a part of the extended neurosonogram, where we need to evaluate the spine in the sagittal, coronal, as well as in the axial scans also. Now, coming to the etiology of the ventriculomegaly, instead of going in detail of the cases and like this, I have decided today to give you an overview about how to approach a case of ventriculomegaly how to evaluate a case of ventriculomegaly when we see the ventriculomegaly, how to go forward. So for that we need to understand the etiology. Also, etiology can be CNS structural anomalies, or it can be aneuploidies, and then it can be fetal infections. So when we say that, yes, I have seen a ventriculomegaly, it is milder or moderate ventriculomegaly. It is like, the treasure hunt. You have to find out clues and then reach to the diagnosis. The same thing. So what things we are going to look in the fetal brain that will reach us to the diagnosis of the main pathology. So for that, these are all the things. Actually, this is though this list appears very long, it is not that difficult. Don't get oh my God, so much. This is such a long list. No, it is very easy to follow this list. And if you follow a specific protocol, and if you see specific sections and what to see in that section, as Dr. Prarthana has very well told us, so it becomes very easy. So now coming to the CSP. CSP is the cavum septum pellucidum. We all know that CSP is the structure which is normally seen as a rectangular area here. So what we have to see in the CSP, we have to see if the CSP is seen or not. If it is seen, how is the shape of the CSP? What is the size of the CSP? So normally the CSP is rectangular in shape, and then the anteroposterior diameter is more than the right to left, the transverse diameter. And the CSP can be like square, or it can also be a triangular. This is the normal CSP. If the CSP is not seen, as in case here you can see, then in this area you may see 3 linear shadows, which are the midline falx and the medial borders of the cerebral hemispheres. So we should not confuse the CSP with this, because CSP we see as a very specific rectangular anechoic area which breaks the interhemispheric fissure. In 3-line sign, you will see the interhemispheric fissure through and through. And also in bundle of probes, it is just an area which may also mimic CSP. So we have to be alert about this also. And then we have to, so the shape of the CSP, the normal shape is a rectangular shape. But if you see a square shape like this, where the anteroposterior diameter is less and the transverse diameter is increased, then you have to suspect something. And to evaluate this, there is a CSP ratio, which is the anteroposterior length divided by the transverse length. And this should be always more than 1.5. So these things we have to evaluate in the CSP. This is a case of partial agenesis, where you can of the corpus callosum. This is a altered shape of the lateral ventricle, the CSP, sorry. And then you can see in the sagittal section, the corpus callosum is seen only in the anterior part, and the same is confirmed by the Doppler here, where the pericallosal artery is seen only this part. So, and this was also again associated with the typical colpocephaly, or a teardrop shaped lateral ventricle. This is normal corpus callosum, as Prarthana has very well showed us. So this you can compare here. You cannot see the complete corpus callosum here. It should reach the tectal plate, but here you can see it is not at all reaching the tectal plate area. Then we don't see the second condition is that when there is absent CSP is associated with holoprosencephaly, and it is a common finding in all types of the holoprosencephaly. And in this, we know that the CSP is definitely absent. Corpus callosum may be segmentally absent. Interhemispheric fissure is absent, and then the circle of Willis is also abnormal in cases of holoprosencephaly. Here you can see a monoventricle is there. The CSP is absent. The midline falx is absent. You can see the fused orbits. The orbits are so closely placed here. The proboscis is seen, which is very well picked up in this 3D picture. Then we have to look for the ventricular margin. When we see a ventriculomegaly, we have to look for the ventricular margin. Normally, we get very smooth, regular margins. But if they're like crinkled like this and irregular with some nodular things, then it could be periventricular nodular heterotropia, a type of migrational disorder. If we see bright echogenic things, it can be interventricular hemorrhage, and when we see calcific foci, we have to think about the infections. This is the second part which we have to see in the lateral ventricles. Then we have to look at the choroid plexus. Is there any pathology of the choroid plexus which is leading to the ventriculomegaly? We have to compare the size and the echo pattern of both the sides. If we see that yes, one of the lateral ventricles is large, it can be because of the interventricular hemorrhage, the blood clots have settled in that, or it can be a choroid plexus papilloma. To differentiate this thing, you have to make use of the Doppler. In choroid plexus papilloma, we can see the vascularity, and here you can see this is the interventricular hemorrhage, and the lateral ventricle is so bright and echogenic here. Then the interventricular hemorrhage, we see various appearance of the interventricular hemorrhage depending on the stage, but I will not go in detail of the staging, but we have to look at the walls. The hyperechoic ventricular walls can be seen. We can see irregular, bulky choroid plexus as because of the settling of the blood clots. And then we can also see the interventricular hyperechoic debris, which can be, at times they are very settled, but though you just like tap the fetus, the position change, then the echoes are seen with the fetal movements. And then if it's a large hemorrhage, then we can see the fluid blood level also in the ventricles. Then we have to also evaluate the content of the retroventricular fluid. Normally it is jet black anechoic fluid. So we can see turbid clots in that. We have to also look for the bands or synecdoche, which will suggest infection. So a turbid fluid with synecdoche, it can be an interventricular hemorrhage or an infection. Then we have to look at the corpus callosum. The presence and absence of corpus callosum. We all know that ventriculomegaly is indirect sign of the absence of the corpus callosum, and that it is having a very typical appearance of a teardrop shaped, also called as colpocephaly. And then in the corpus callosum, we have to evaluate the length, the thickness of the corpus callosum, basically in the mid-lateral view. And here you can see this typical. Here you can see the CSP is absent, and this is the typical teardrop shape. And this is the complete agenesis of corpus callosum, where you can see this lateral, the sunburst, typical sunburst appearance is here. So the corpus callosal evaluation is also a very important part. Next, we have to look at the cerebral hemisphere, where we have to compare the volumes of the two hemispheres and look for if there is any asymmetry there. If we find any asymmetry there, then it can be because of unilateral cerebral hypoplasia or cerebral atrophy, and then it can be secondary to hemimegaloencephaly. Basically, it is a hemimegaloencephaly is a hamartomas overgrowth of all of the parts of the cerebral hemisphere, and we have to identify these conditions also. Then a very important thing we need to evaluate is the subarachnoid space. The subarachnoid space, it can be, this is a very nice paper if you want to further read in subarachnoid space. So it can be normal, it can be increased, or it can be decreased. So if it is, we don't see the subarachnoid space, it could be because of the very tightly fitting cerebral surface to the like the skull, the inner part of the skull, and it could be because of the obstructive hydrocephalus. And then when the CSS stresses are increased, it can be because of the cerebral hypoplasia, or it could be because of the cerebral atrophy. And then we have to look at the cerebral parenchyma also, because this cerebral parenchymal evaluation will point out to the major abnormalities, or it gives clue to the pathology of the the ventriculomegaly. So we can get cerebral atrophy, we can get the presence of the clefts like this, which are secondary to some insults, which could be unilateral or bilateral. Then we can have a delayed or premature sulcations like in lysencephaly and premature sulcation, or like in lysencephaly and the polymicrogyria. And then we have to look also for the periventricular area for any periventricular halo calcifications or the cyst or any solid nodules. And then we have to also look for the parenchymal solid or the cystic lesions like tumors, bleeds, cyst, or the teratomas also. For the cerebral parenchymal evaluation, and all these can be very well done with the basic axial and the extended neurogram. All will help us to, these sections will definitely help us to evaluate the total CNS anatomy. And then, as Dr. Vaishali has very nicely explained now, just before this talk, the posterior cranial fossa, we have to look for the vermis, we have to look for the cerebral hemisphere, the vermian size, sorry for that block. Then the cerebral hemisphere, the sizes, the size and the symmetry of the cerebellar hemisphere we have to look for. Then we have to look for the cisterna magna, and the pathologies very well described by Vaishali. I won't go in detail of this. And then we have to do the Doppler evaluation of this brain pattern for the evaluation of the pericallosal artery. And then we have to also look for the any abnormality in the circle of Willis area, and then we also have to look for the venous part also of the brain. And then after evaluation of the CNS, of the evaluation of the brain, then we have to go for a very detailed targeted anomaly scan. In this, we have to look basically for all the markers. As you can see in this chart, this is a very very famous chart by Agatha Clausita, where they have given certain likelihood ratios, and you can see here that the isolated likelihood ratio for the isolated ventriculomegaly is very high, 3.57, and we have to evaluate and understand that all the markers, if they are seen or not, and if markers, additional markers are seen, then the risk changes. How the risk change, that is a different topic, but then we have to recalculate the risk and then do the further evaluation. And then we have also to evaluate for the fetal, see for the findings of any fetal infections other than in the brain, and then a detailed fetal echo is also required to rule out any cardiac anomalies also. Now coming to basically the severe ventriculomegaly. Till now we have seen about the mild and the moderate ventriculomegaly. So severe ventriculomegaly, basically here the atrial, the width at the level of the atria is 15 or more than 15. Again, it is classified into two types, that is obstructive hydrocephalus and the severe lateral ventriculomegaly, which is associated basically with the malformation of the cortical development. So it can be obstructive or it can be passive because of the surrounding parenchymal disorder. So basically obstructive hydrocephalus. So basically hydrocephalus, when in ventriculomegaly, when the terminology hydrocephalus is used, it is specifically used when the pathology is obstruction. So otherwise it is only a ventriculomegaly which is used, and when a specific hydrocephalus comes, that means it is an obstruction. This we have to understand. So the hydrocephalus obstruction can be at the level of the foramen of Monro or aqueduct or at the fourth ventricle. And the common causes are basically aqueductal obstruction or stenosis secondary to some hemorrhage infections, or it can be Chiari 2 malformation, it can be Dandy-Walker malformation, intraventricular hemorrhage, tumors and cysts, all causing obstruction at various levels. So this is regarding the severe ventriculomegaly. Now obstructive hydrocephalus. So basically, commonest of this, the cause is the aqueductal stenosis. So we know that in aqueductal stenosis, the proximal part will be dilated. So it will be the lateral ventricle and the third ventricle which will be dilated. So you can see here the lateral ventricle and the third ventricle here is dilated. The parenchyma becomes very thin. Now because the pressure here is increased, the subarachnoid space is obliterated. There is effacement of the sulci, and then there is compression or obliteration or destruction of the CSP also. There can be dangling choroid plexus cyst, and here in this we have to remember that the posterior cranial fossa is normal, because now the obstruction is the level of aqueduct. The distal part will be always normal. Aqueductal stenosis can also manifest in late pregnancies also. So at anomaly scan, it can be normal, but later on the obstructive hydrocephalus can develop. So we should also remember this. Then cherry malformation. The obstructive cause, the commonest is the cherry malformation, cherry 2 malformation, where there is displacement of the cerebral tonsils, part of the cerebellum, fourth ventricle, pons medulla through the foramen magnum, secondary to drainage of the CSF from this open spina bifida with this type of lesions. So here we get the specific ventriculomegaly and the typical lemon and the banana sign, which Shali has very well explained. So this is a very common cause of the obstructive hydrocephalus. And then infections as a cause of ventriculomegaly. So 5% of mild to moderate ventriculomegaly, we get infections. And the commonest infections which are they are because of the cytomegalovirus, the toxoplasmosis, and the Zika virus. And sporadically, ventriculomegaly can also be seen in mumps, parainfluenza virus, and the parvovirus. So how does the infection causes ventriculomegaly? So basically, this virus have a very great affinity towards the periventricular area where the new neuron formation and the migration occurs. So because of this damage and this thing, there occurs gliosis, and that leads to cerebral atrophy, leading to ventriculomegaly. Or there can be ependymal stenosis at the level of the aqueduct, and that leading to stenosis because of inflammation. The ependyma becomes edematous, and that leads to stenosis, because we know aqueduct is a very, very thin tube which connects between the third and the fourth ventricle. And then there can be inflammation of the arachnoid granulations, which will hamper the absorption of the CSF, or there can be inflammatory excessive production of the CSF by the choroid plexus because of the inflammation of the choroid plexus by the viral infection. So all this can lead to the ventriculomegaly. Now, how is the presentation? On ultrasound, we will get periventricular hyperechoic bands. Here you can see these typical bands which we can see, or we can see a very tiny periventricular small cyst. Periventricular calcifications can be seen. Then this periventricular hyperechoic nodules like thing can be seen. We see intraventricular synecdoche also, and this type of periventricular or parenchymal non-calcific nodules can also be seen. These are the things we see in the CNS, but also when we see such type of suspicious finding of infection on CNS, we have to evaluate the fetus in toto, where we look for the detailed fetal abdomen and other things, where we can find the hepatosplenomegaly, calcific foci, ascites. We can get meconium peritonitis, congenital cataract, microophthalmia, and cardiomegaly also. Polyhydramnios, thick edematous placenta, microcephaly, and IUGR. All this can be like associated with the fetal infections. And now genetic disorders which lead to the ventriculomegaly. So nearly 5% of the fetuses with apparently isolated, sonographically apparently isolated ventriculomegaly have an abnormal karyotype, which is commonest is the trisomy 21. And then 10 to 15% also have an abnormal microarray. In male fetuses, where there are repeatedly male fetuses having a ventriculomegaly in certain families, it can be an isolated X-linked idiopathic hydrocephalus, and then that needs to a separate evaluation. And then there are various syndromes where the ventriculomegaly and other findings are associated, which include, there's a long list, but some of the common are like the Walker-Weber, the Bardet-Biedl, Meckel-Grubers, then Jobbers, and the hydrolysis. These are few of the genetic disorders which are associated, and therefore we have to do a very proper counseling of these patients and explain them everything. So now, should an MRI be done for every fetus with ventriculomegaly? Actually, if you are very, you do a proper neurosonogram with good machines and a good expertise, then the need of MRI is not that much it has having hardly any superiority. There was a study which showed that MRI, that hardly some 15% extra findings can be get when we do MRI in this patient. Basically, ultrasound itself is a very good thing. But yes, when there is poor sonography penetration and you suspect that there is nothing there, and you have to say that yes, this is only an isolated ventriculomegaly, then at such time you have to go for a MRI in obese patients. And then for detection of the subtle neurodevelopmental anomalies, the anomalies of cortical malformation and the myogenital disorders, evaluation of the sulci and gyri, the MRI becomes important. But again, MRI will be best in the third trimester onwards. So if you have if you are expert and good machines and detailed scanning is done, then the chance of MRI is, the requirement of MRI is quite less. But yes, if you want to involve some of your, whenever there is some pathology in the fetus and we involve, have a multidisciplinary approach or multiple people are involved, then, that what you can say, the responsibility can be distributed. So for that also, if you require, you can go for the MRI also. Now we have to understand these two concepts of unilateral ventriculomegaly and asymmetric ventriculomegaly. So unilateral ventriculomegaly can be unilateral because of the obstruction at the level of the foramen of Monro. Though unilateral ventriculomegaly is rare, it can be seen in parcinogenesis of corpus callosum and very commonly in infections, where the foramen is obstructed because of the some debris and other things by the infections. And when do we call it as a asymmetric ventriculomegaly? When the difference between the ventricles is more than 2 millimeters. We have to understand that asymmetric ventriculomegaly, basically it is having a very bad prognosis, basically because it is usually associated with ischemic or post-inflammatory causes. And ischemic things, as we all know, that it is a end stage, end organ disease, whatever you can say, it becomes a very poor prognosticating thing. And then symmetrical ventriculomegaly, a study was formed, and where they found that as compared to asymmetric ventriculomegaly, symmetric ventriculomegaly was associated with more CNS findings. So we have to understand the unilateral ventriculomegaly as well as the symmetric and the asymmetric ventriculomegaly. Now, how should we approach to a fetus? How should the fetus be evaluated when there is a mild or a moderate ventriculomegaly? So we have seen about the ultrasound criteria. We have to evaluate all the planes and all the things, the 11 or 12 points which I have told, which area we need to evaluate in detail and what to see is that part we have evaluated. Then we also have a very important thing about the biometry, the microcephaly and other things also we need to evaluate. Which the biometry will help us in the same thing. Now, for testing of the genetic disorders. So the testing of the genetic disorders, basically, should we go for the evaluation, genetic evaluation? Basically, the decision depends on the presence of the other abnormalities, the other soft markers, and the first trimester screening. And depending on this, we again have to recalculate the risk and then suggest the evaluation in these fetuses. Then it can be like amniocentesis with CMA, or you can go for the cell-free DNA. But also we have to understand that ventriculomegaly with a normal screening test, preferably describe everything to the patient and then ask the patient to take its own decision. But still having a diagnostic test will always be a preferable thing if the anxious patients are, we have to like explain all the things to the patient, though the decisions can be taken by the patient. They are going to take the decision themselves, but you should always make clear all the things and the evolving things and everything to the patients. And then when we suspect fetal infections, we have to ask for the history of potential exposures. If she has gone to some area where the viral infections like the Zika virus and they are very common. And then we have to go for the PCR test for the amniotic fluid, which is very accurate. But these tests need to be done after 21 weeks of gestation because it takes around 6 to 7 weeks for the fetus to excrete the virus in the urine. So after 21 weeks onwards, the PCR amniotic fluid will be more accurate for the fetal infections. And then we have to go for maternal serum tests also for the IgG antibodies and with the avidity for the CMV and the toxo. You all know this better than us. So the testing for fetal infections is, it depends on the history of the patient. Then what is the management in cases when we detect the mild or the moderate ventriculomegaly. First and foremost important thing is the counseling from all the healthcare providers. It should be a team basically which will involve the obstetrician, the radiologist, the maternal fetal medicine specialist, genetic counselor, pediatric neurologist, and neurosurgeon. So when all this together, they have a very good team approach. That counseling becomes very helpful for the patient, and we have to discuss with the patient. We have to inform the patient that the prognosis varies widely based on the exact finding of the complete prenatal and postnatal evaluation. Postnatal evaluation is very important. That we have to tell the patient that prenatally we cannot say surely about what the things will be like, and postnatal evaluation will be helpful in these cases. And then the follow-up scans are very important. And in the follow-up scan, this paper, which came a few years back, they say that in nearly 34% of the mild moderate ventriculomegaly, there is regression, while the ventriculomegaly remains stable in around 56% of the fetuses. And when there is regression or the ventriculomegaly is stable, then only 4 to nearly 4% of the fetuses will have a risk of the neurodevelopmental delay. But if the ventriculomegaly is progressive, which occurs in around 16% of the fetuses, then the chances of having a neurodevelopmental delay is very high. And that we have to explain this to the patient and let them take the decision finally. So this was again one paper about what happens in the infants with mild ventriculomegaly. So with isolated mild ventriculomegaly, the survival rate was around 93 to 98%. The neurodevelopmental delay was nearly 8%. More than 90% have a normal development, which was not different from the normal population. And then, depending on this paper, what they recommend that with isolated mild ventriculomegaly, after a complete evaluation, the woman should be counseled that the outcome can be favorable and the infant is likely to be normal. But here, when we say that it is isolated mild ventriculomegaly, the word isolated means we have to evaluate structurally, sonographically, genetically, as well as infections. And then we have to say that it is an isolated ventriculomegaly. When we report as a radiologist, it is an isolated ventriculomegaly, it is sonographically isolated ventriculomegaly or apparent isolated ventriculomegaly. A complete isolated ventriculomegaly means it is better to go with all the investigations. And in moderate ventriculomegaly, the chances of neurodevelopmental delay are from 7 to 25%. And then again here also we have to counsel the mother that the chances are quite good, nearly 75% chances are like good, but again there is an increased risk for the neurodevelopmental disabilities in these infants. So to conclude, we have to understand that ventriculomegaly is not a diagnosis. We have to evaluate to find the clues and reach to the diagnosis. We have to do the grading as mild, moderate, severe, extended neurosonogram to evaluate the structural and neural cranial abnormalities and also the extracranial abnormalities. For that, we need to go for the TIFA scanning with fetal echo and the detailed evaluation of the second trimester markers. We have to look for the signs of infections. And then when all these things basically on sonography, these are things we see that nothing is there and only ventriculomegaly is there, then we say that it is a sonographically isolated ventriculomegaly or apparently isolated ventriculomegaly. But then in these patients, we again have to evaluate for the infections, explain the detail about the genetic testing, give the choice of genetic testing, have a genetic consultations. And if you feel a team approach and again counseling with other like neurosurgeon, neurophysician is also important. Then follow-up scans are very important. If the parents decide to go ahead with the pregnancy, then serial follow-up scans are very important. And in each and every step, counseling is absolutely important to help the patient out to take the decisions, and even for us also, it becomes very important. So thank you very much for your patient listening.
Thank you, ma'am. I'll request chairpersons to share their remarks. Lalita ma'am, Prashant sir.
Excellent talk by Dr. Shilpa. You have explained everything about mild, moderate, and severe ventriculomegaly, and how to come to the conclusion mild, moderate, and what will be the prognosis. The team approach is very important. Everything you have explained very nicely. Thank you. Thank you.
Thank you.
With this, we'll conclude the academic session. I'll present the vote of thanks. We are thankful to Dr. Sita Ramurthy Pal Madam, Chief Guest, then Rajendra Singh Pardesi Sir, Sujata Dalvi Madam, our President and Secretary of AMOX, our Fetal Medicine Committee Chairperson Dr. Sujit Konkar Sir, who has taken tremendous efforts for our webinars, then our President and Secretary Dr. Anjali Vare Madam and Vaishali Surase Madam. We are also thankful to Chairpersons Lalita Bajaj Madam and Prashant Ingole Sir. Lastly, our esteemed speakers who have enlightened us with great knowledge, Dr. Prarthana Shah Madam, Dr. Vaishali Munde Madam, and Dr. Shilpa Satarkar Madam. Really all were excellent lectures. Also, we are thankful to our academic partners, Shield Healthcare and Mr. Dr. Stalin Sir for their educational support. Thank you, everybody. Last and not the least, our audience, we are also thankful to all of you.
Thank you.
Thank you.
Thank you very much.